G'day and welcome today to Endo Untangled. My name is Alicia Macro. I'm a GP with a special interest in endometriosis and pelvic pain, and I'm joined by Cherie Noble, accredited exercise physiologist and endo navigator in our endometriosis and pelvic pain clinic. I'd like to say, Cherie, welcome to the podcast, but I am the subject of today's podcast. I am the guest, so welcome to me. I'm just saying Cherie made me do that.
And I did actually make you do that because she introduces the guests. So let's continue with the format.
So since I'm introducing myself, what today is about is just a bringing together. So, of course, we can't summarise what have been our 21st episodes, which I would say, well done us.
Yeah, go us.
Apparently less than 1% of podcasts ever make it to the 20th episode.
Wow.
So yay us.
Well done.
And I'm not sure if I've said this on air before, but I've certainly said it to you 900 times. Someone has said to me in the past when we started this podcast, how on earth are you going to do a podcast on endometriosis? And it's like, we're 20 episodes in and we are literally just getting started.
It's just scratching the surface, tip of the iceberg.
Yes.
Yes.
And I think that's what's been so disappointing about the way that pelvic pain endometriosis has been approached in the past is it's been a very one-dimensional look at endometriosis. This problem is not the 2 paragraphs that are in the textbook. It's not the 15 minutes in the lecture that doctors got in medical school. There's a lot going on. Yeah. So what we were hoping to do, or what we decided to do, is that we would turn things around and you get to interview me.
I get to ask the questions.
Take it away.
Yes, which came from my new role as endo navigator.
Yeah, tell us about that.
Which has been such an important role that I've really, really enjoyed stepping into, and just the things that I've seen in the short time in that. I mean, I've been involved in it for as long as you have as well, but having this lens has really opened my eyes to your expertise, how you run the clinic, the other doctors that are involved, and thought it would be a good time to just consolidate all the information and expertise that you have, considering that you have seen, or the practice has seen, for over 450 patients now. So we've got a lot of experience in this space. So,
Cherie, do you want to elaborate a little bit on what the endo navigator role is that we have within our Thrive Endo Clinic and what that looks like?
Yeah, so I'm meant to be interviewing you.
I know, important.
So see that deflection. Yeah, I love that.
I don't like talking about myself.
Yeah, the endo navigator role is the first point of call for patients when they come into the practice, and it's really a fact-finding interview. Well, it's enabling people to tell their story as well. So where have you come from? Let's look at all of the things that are contributing that you're experiencing. So we unpack the journey so far, what your problems are, what barriers that you're experiencing, and I guess asking a lot of questions. It is quite an intensive interview, which hopefully I navigate in a very trauma-informed, patient-centred way, so that we can gather all of the information, provide some education, so that we can really be effective with when you do see the GP, really be effective with that time utilised. Did I do that justice?
I think you did, and also you're sort of coordinating. You're helping people find a pathway through the process that helps them, supporting our doctors, because certainly it didn't take us long to work out that even spending an hour with the GP isn't enough time. So actually, really often that's around 2 hours, an hour with someone like yourself, an endo navigator, and then up to an hour with the GP is a good place to start.
That's how complex this is.
Yeah.
And you're right, like it hasn't been given the time or justice that it needs.
Yeah.
And even then, you're right, we do run out of time, and it's a lot to navigate. I keep using that word, but
it's your job, mate.
But it is what you're doing. You're navigating the system. You're navigating your situation, and I guess it's a triage, isn't it? It's like, okay, not just triaging you as a patient, but triaging your symptoms, what you're experiencing, so that it's not so overwhelming. And that's what we're going to talk about today, because there's a few things that we generally need to tackle. Not that we're going to generalize people, because this is very, very individual, but seeing so many people, we do see a pattern or a cluster of symptoms and things that are going on that most people, if we address, that they do start to make their way forward. Would you agree with that?
Definitely agree.
Yeah. So what have you learnt in this time, Dr. Macro?
Okay. So I think you're right. So we did a recent audit of the patients that we've had through the clinic, and we've gone past 450. And so that is 450 women or those assigned female at birth and there have been a few men. Interestingly, with the grant, it wasn't intended to cover men. But we certainly have seen men, so not through the sort of formal program, but what we find is that the approach is very similar anyway, is that we've got to look at the big picture. So we've got to spend some time understanding someone's whole story, and we can't just skip to the bit about the endo or the endometriosis or the lesions or the laparoscopy or any of those things. What I've really distilled down my practice to, which I feel like I talk about every day in clinic, is that pelvic pain does not have one driver. And it also doesn't just have one initiator that gets it started. So pelvic pain is a complex multi-system problem, which usually takes time to get itself going. And it is never just caused by one thing, in my opinion. There is usually multiple factors going on. Most people's systems can manage one or two of the problems without the development of a pelvic pain syndrome. But once there's a few things going on, that's where people develop pelvic pain. And the way I see it, and I would say with this is my experience and my reflections on working with a lot of people, hundreds of people. So I do own these as my own opinions. Yeah.
Yes. And we like I said, we are pulling out common themes that we see, not saying that this is what happens.
Absolutely. Everybody's different. But I wanted to share, and some of these we've shared during different parts of the podcast already, but I thought it was worthwhile revisiting them. And so the first slide, for those who are watching video, otherwise I will try to pop a link onto the show notes as well, is a slide that I developed just to try almost to help me understand the process, but also to help others understand that pelvic pain doesn't just have one origin. And so that's my pelvic pain initiators. And so what I drew was a funnel, and we almost worked on this together.
Yeah, I know.
So when we developed some of these resources prior to presenting our thoughts on pelvic pain to the South Australian Select Committee on Endometriosis, which was now a couple of years ago. And the funnel came about because I was just really trying to get my head around that it's not just one thing. So it's not usually just the endo that's causing someone's pelvic pain. So if you have a look at the slide, there are a few layers of different causes of endometriosis and pelvic pain. There is one which is endometriosis, and that's quite a big one. But there's also another big factor, which is trauma. There is also neurodivergence, which we've also covered in the podcast, and we'll need to go back and cover that in more detail as well. There is hypermobility. There is what's called the ACEs, which is jargon for adverse child experiences, like any sort of neglect or trauma from childhood, any sort of disadvantage in childhood. Life disadvantage definitely is part of the picture as well. So what haven't I covered there?
UTIs.
Yeah, other things that can go on in the tummy. Yeah, adeno. There is, I've
POTS.
seen, yeah, I think so. Yeah, I think POTS is part of the picture. Just the overall load. It's like a threshold needs to be reached. And then once you reach the threshold, and of course, if you look at that funnel, there's multiple things on there. And someone quite rightly pointed out that you don't have to have all of those things. No. You don't. But usually there is a number of those things going on. And there may be other things going on that aren't on that drawing, of course, that once a threshold is reached, you go down the funnel, and at the other end of the funnel is the pelvic pain. And once you have developed pelvic pain, which is stuff that we've talked about on this podcast before, it is the beyond the cycle, it's beyond the period time, it's beyond, it often starts with the mid-cycle or the ovulatory pain, and often over time it becomes a daily pain that is more than just what's happening with your menstrual cycle. There's often back pain, there's often bowel problems, there's often vulva, there's often bladder. There's so many other things. There's leg pain, there's back pain, there's
headaches.
hip pain, there's headaches, there's fatigue,
Yeah.
there's mood disturbance. All of those things are going on. And that is beyond the endometriosis and beyond the lesions. It's almost like your body gets into a new steady state. So in medicine and in healthcare, we talk about the state of homeostasis, which is where the body keeps itself regulated in a fine balance. And most of the time, for those of us lucky not to have persistent pelvic pain or any other persistent pain, we might have pain episodes, but we come back into that homeostatic balance. It's almost like being in a bowl and you can pop out of the bowl, but then you pop back into the bowl. But what does happen with pelvic pain, in my opinion, is that if there's enough going on, you go into the new bowl. The happy pain-free bowl isn't you anymore. You're in the
pain bowl.
You're in the pain bowl.
Yeah.
And your body will self-regulate to keep you there. It's not a conscious thing. It's not like you're thinking, oh, I'm benefiting out of being in pain. Of course, that's not the case. But
it's just the new normal.
It's a new normal, and the system keeps you there.
Yeah.
Not the healthcare system, although sometimes you could argue that that's the case.
Yeah.
Your own physiological
system.
systems keep you there, and we need to identify that. We need to acknowledge that it's going to take time to get out of that place again, and then we need to look at the barriers that are keeping that system in a steady state, which is stuck in the pain bowl.
So these are the pain initiators.
So the pain initiators are those things that get pain started.
Yeah.
Endometriosis, chronic infections, bowel infections, overuse of the pelvic muscles, hypermobility, adverse childhood experiences, all of those things, they're the pain initiators. So that's what pushes you into the new bowl.
And do you find even just sharing this with patients, you kind of can see that the light bulbs go on and they're not even aware that this was a link?
I think a lot of people don't realise that there are other links because understandably, and it's been a good thing that there's been increased conversation about endometriosis, which is wonderful because 20 years ago there wasn't any conversation about it. There was no awareness about it. But I think that the modern conversation has developed into endometriosis equals pelvic pain, which is an oversimplification of the problem. And we know that you can definitely have endometriosis and not have pelvic pain because we see that too. Yep. And often we'll see women who are incidentally found to have endometriosis, which can be quite significant, or they are found to have it when they're being investigated for their infertility, which is being often driven by the inflammation from endometriosis. So we know that endometriosis doesn't equal pelvic pain. And we certainly see that there's people who can have pelvic pain just the same as people with endo who don't have any detectable endometriosis, who have probably been pushed through that funnel by other means, whether that be a combination of bowel problems, neurodivergence, hypermobility and other things.
All the things.
Yeah. So,
all the things.
Yeah. So although endometriosis at the moment has been a sort of sexier topic, there is an unsexiness of complexity going on that will put someone in the new bowl. And it has to be a quite significant combination of issues going on that put someone in a new bowl. And you're right, some of those things that people who are coming in to see me don't realise that are happening. So they may not realise that if they have had a history of trauma, or if they have suspected neurodivergence, or even if they're not aware that they may be neurodivergent, they often aren't aware if they have a coexisting hypermobility syndrome, which I'm sure we'll talk about later. And they may or may not have been properly diagnosed or identified as having endometriosis or adenomyosis or other things.
Yeah. I think it's just important for that. It allows that window to be open to that curiosity of like, okay, well, I didn't consider these things and maybe I've been thinking too narrow about what this pelvic pain or my symptoms are and what the contributing factors to getting here is. And then because that's an important part of the story and a bit important part of the picture for then unwinding this and coming out the other side.
Yeah, that's why we talk about zooming out, don't we? Because if you're too zoomed in, you're missing all the other stuff that's going on. And that's not an individual's problem or fault. There's been this huge, I want to say industry, which sounds very cynical, around endometriosis. There's been a lot of work done on endometriosis, which is important, but if someone's got pelvic pain and we're only looking at or thinking about their endometriosis, in my opinion, we often can't get them better.
It's a disservice.
Yeah.
Yeah.
So we've talked about the pelvic pain initiators. So they're the bits that get the pain going. But in my experience, the thing that gets the pain going is not what keeps it going. So what we developed is a different idea or a different slide to help us understand what are the factors that keep people stuck and keep the pelvic pain in motion. And we came up with the idea of Newton's cradle, which are the swinging balls which can keep the system going in perpetual motion.
Yeah, because they keep hitting against each other.
Yes.
To keep it, yeah. So the menstrual cycling, the pelvic floor, the bowel, bladder, and nervous system, all just hitting each other continuously, having an impact on each other.
And they're the swinging balls.
The swinging balls.
And the other thought that I've had subsequently is in a hypermobile person, it's almost like the cradle itself is made of silly string, and that's just moving around in 4 dimensions while everything else is going as well. But that's our swinging balls.
Yeah.
When I talk to someone who has pelvic pain, I say this to everyone: we must consider all 4 of those parts of the problem, because if we just focus on any one of them, we probably can't get you better. And unfortunately, with the more recent interest in surgical management of endometriosis, which can be important, but covering that without thinking about the rest is unfortunately not helping people to get better. And so that is my real take-home message that I feel like I say many times a day.
You are absolutely the one who has agency and control over
Yes,
this.
absolutely.
But we need to consider these things, and let's have an open discussion around this.
Yes.
So
in a recent podcast with Dr. Jessica Floriani, we started to dig into some of the different types of, if we're thinking about hormonal or menstrual cycling, we've started to look at that, and there's so much there. And it just goes to show how complex this is, that you can spend an hour podcast with an expert trying to unpack this and you only get a little way of the way through. There's really a lot there, but definitely encourage people, if they're thinking about that menstrual cycling horse of the apocalypse, to go back and have a listen to that and have a think about that, because one of the key concerns or worries that people have when they come and see me is it appropriate to be stopping your menstrual cycle? And I would say if your menstrual cycle is causing you pain, then usually it is appropriate. There's always going to be an individualised approach to that. But being open to and considering that as a key part of your management is really important. Same with considering, any degree of endometriosis lesions, where they are, what they're doing, is also an important part of the management. And we have also discussed that, for example, when we interviewed Dr. Matthew Leonardi on the podcast last year. And again, it'd be great for those who are interested in the surgical side of endometriosis management to have a review of some some of his ideas.
Can we take a little bit of a side tangent? Let's go on a little side quest here, which I'm good at.
Like a side quest.
Love a side quest. Sometimes it is important to get a diagnosis, and we will refer to, a good quality scan or MRI so that we can detect it. Like, when is it appropriate and when is it not, in your opinion?
To get a scan done?
To get a scan done, to get the diagnosis. And we talk about that a little bit with some patients.
Yeah. So, I mean, perhaps if we even go on a bigger side quest than that, it's not
You can always one-up me, can't you?
So if we really sort of backtrack even further on that, it's not that long ago that the language used was to have a diagnostic laparoscopy. So if you've got query endometriosis, the next step in diagnosis, because you can't treat before you've got a diagnosis, is to go and operate and have a look. And those days are disappearing rapidly, which is good.
Good.
Because nowadays, if someone's got symptoms of endometriosis, we can go and have a look to see either by an MRI or a high-quality ultrasound, which, again, we've covered in previous episodes, to see if there are lesions that we can see of endometriosis. But you're right, even that's not necessarily where we need to start. So if someone has got symptoms that sound like it could be endometriosis, they've got pelvic pain, they've got bad periods, it can be appropriate to consider whether that person might have endometriosis. But often getting that sort of information doesn't need to we don't need to do that to get on with management. So one of the first things you get taught in medical school is, if you're thinking about organising an investigation, to consider how getting that information is going to change your management. And usually the suggestion is that if that intervention or if that investigation isn't going to change your management in any way, then you really need to be thinking about why you're doing that.
Yeah.
And so,
because there's cost involved, there's time. I mean, you already got, a number of appointments. You've got to make another appointment. There's a lot of things that are going into getting that scan done.
And if you're talking about the bad old days, which is in some cases still happening, the idea that you need to go and have a surgical procedure to get that information, which may or may not actually change your management later, you really need to think about whether or not that's a necessary step. And there's no one size fits all here. So I think we'll say this over and over.
We will, yeah.
This is really generalised advice, or at least something to think about.
Education.
It's like, is what's being proposed going to change my management? Because if I meet someone new, and that might be someone who is, say, a young woman who might be in her mid to late teens, who has symptoms suggestive of endometriosis, got bad pain, starting to get pain in between, in various parts of the cycle, might be missing school, might be missing work, that sort of thing. Or even we see someone who later in life is having these problems. Getting a diagnosis isn't necessarily going to change what we do.
Yeah.
There are occasionally times where it will change the management, particularly if we've got particular questions we need to answer around fertility, or whether there might be adhesions which might be causing an issue in the pelvis. But in general, if we're looking at those 4 things that we need to manage: menstrual cycling, thinking about bowels, thinking about pelvic floor, thinking about nervous system, we don't require a diagnosis to get going on any of those things. And so for many people, I would suggest to them that we could definitely get started working on those 4 things, and then we can save the investigations plus or minus the surgery for the times that people aren't getting better as we expect. Investigations that may change our management at that early stage are things like checking for a thyroid problem or an iron problem, or a problem with blood clotting if needed, or doing a swab and checking to see if someone actually has chlamydia or gonorrhea or mycoplasma or one of the sexually transmitted infections, doing examination, HPV testing, pap smear, to make sure that there's not something nasty going on there in terms of cervical changes, cervical cancer, thinking about whether or not someone needs to have a colonoscopy or not, and that, again, is its own nuanced conversation. Those things would change our management. So say if I get someone to do a swab and they're positive for chlamydia, we're going to treat that, because that can obviously contribute to pelvic pain. And we would not want to get on with managing the other 4 horsemen while someone had an undiagnosed chlamydia, for example.
So it's really important to have those screens ticked off.
Screening done, and that's where having a GP or a clinician who's experienced in this area working with you to make sure that we're not missing some of those things.
Ticking off all the boxes.
Yeah, so a chlamydia test, if necessary, yes. A diagnostic laparoscopy, almost certainly not required. An endometriosis scan of some type is something to consider, but isn't strictly necessary to get on with things. What I would say, though, there are some people who have had a lot of diagnostic delay. They have been mucked around, for better or worse, in the system. They've seen lots of different people. They've never had an opportunity to identify if there is endometriosis there or not. I'm not standing in the way of any of those types of people if they say, I really need to understand if there's endometriosis here. That's fine. But I also say to them, you've got all these symptoms. If we do your scan and there isn't endometriosis there, if we can't see any endometriosis, that's also okay. You've just had different elements of the funnel that have pushed you into that new place.
And there's still things that we can do.
And the things that we do
things
are
that we will do anyway.
The same. Yeah, they're predominantly the same, because whether or not, from a cycling point of view, you do have that neuroimmune trigger every month. If you're getting painful, heavy periods, regardless of whether there's endometriosis there, it's helpful to manage those, and it's helpful to make them go away. So,
absolutely.
Yeah. So those 4 things. And if you're at home, if you're listening and you've got pelvic pain, just stop. I encourage you to stop and go, okay, what am I doing about my cycling, my bowels, my pelvic floor and my nervous system? And you need to have I suggest you need to have a solid approach to each of those 4 things.
Yeah, absolutely.
And we can talk through what those things might be.
Yeah, well, let's talk about the bowel. Let's go there.
Oh, bowel. Okay,
yeah, let's get into
it. Yeah.
Yeah, because I think people underestimate the influence that our bowel has on
pain.
On pain.
Yeah. Overall well-being, but also as a driver of pelvic pain.
Yeah.
So again, if we were just part of this is just to kind of try and bring together some of the episodes that we've done.
Yes.
Episode number 8, by far the most listened to and downloaded episode so far on the podcast, is Dr. Chris Gillespie, colorectal and pelvic floor specialist surgeon, talking about how the bowels get involved with pelvic pain. My suggestion is that a lot of the time, bowels are really, really not functional, and they are usually what we call, people are usually fecally loaded.
Yeah.
I like to avoid the term now constipation because you can be fecally loaded, which means if you look at your bowels, say if you've had an old CT scan or an MRI, we can see that they're like chockers to the hilt, but someone can still be going regularly, or they could be having diarrhea.
Yeah.
Or sort of loose stools. They don't necessarily feel like they're constipated because they're going all the time. Or the other thing that we see is that, you know, we look at the Bristol stool chart where there are different types of poos from very constipated to diarrhea. People can say, well, I can have any of those on a day, or sometimes I could have all of those different options on a day. And so you can have that going on and still be fecally loaded. And
which is just telling us that it's not functioning optimally, is it?
Yeah,
which is
that's right.
Yeah.
That's right. And that's called it's dysfunction of the bowel, which isn't it's not anatomical in that if you have a colonoscopy and this is going on, your colonoscopy looks normal. You empty your bowel and you stick your camera all the way around there. It looks fine. That's important to know for some
important to rule things out.
Yeah, that's right.
But doesn't mean that there's a functioning bowel. Is that correct? Or
correct? Absolutely. And so, I mean, again, there's more nuance here because not everyone who has sort of dysfunctional bowel needs to go and have a colonoscopy, but it's certainly something we should think about whether or not it's necessary, because we don't want to miss someone with a bowel cancer, and we all know that bowel cancer in young people is on the rise, and we don't really understand why. So that to the side, you can have a completely normal looking bowel at colonoscopy and have a completely screwed up bowel in the sort of day-to-day function.
Yeah.
And one of the main drivers of that is the outlet. There's an outlet obstruction. So where the muscle should relax to let you do a proper poo to let everything out, which should be able to clear like the whole descending colt, like the whole lot should be able to come out if it's there. Often you'll only get a bit of that, and we often ask in clinic if you're fully emptying your bowels or not, if you feel you're completely emptying, and many people will say no, and that's a really helpful clue. And so, yeah, so that's a really important thing to be thinking about. The other thing that can drive it, and we'll come back to, is some people have stretchy bowels, which means that they can accommodate a lot of poop. The other thing I was going to say is I don't know the reason for this, and I don't know if it's been written up. I've not seen it written up in the literature anywhere, but clinically, the picture that I often see with pelvic pain and bowels is that people will have a sausage, like a big fat German sausage, or big salami of poo, starting where they kind of think about where your right ovary would be.
Yeah.
But I will feel, and you can feel that sausage is undercalling it. It's a salami on that side. Bloody sore. It really is painful, and it's concrete. And so that's sitting there, and the wet, loose stuff comes around.
And how does that contribute to pain?
Well, it's sitting there. It's sore. It's causing sort of those stretch receptors to go off. And yeah, it's just not moving around. And so it's painful. So if I press on that bowel full of poo, it's sore.
Yeah.
And I
guess it's driving inflammation.
It no doubt drives inflammation. And there's often sort of mucus production because the body's like trying to naturally
That's
lubricate.
One of the questions we ask as well.
Lubricate the way through. And things just aren't moving around properly, and often that wet stuff. My colleague in clinic at Thrive, Dr. Kylie Booth, who often has entertaining ways of explaining things, is she'll sort of talk about the bowel in terms of it's a bit like having a traffic jam on the Sydney Harbour Bridge. So particularly if there's an outlet obstruction, so say, the 4 lanes of the Sydney Harbour Bridge is down to 1, so there's our outlet, there's our puborectalis not opening properly. The cars aren't getting through, so you can be sitting in a car not moving anywhere, So the cars aren't moving anywhere, but the motorbikes will get through. And so if you're having that sloppy, wet poo, sorry to be sort of,
But they're the motorbikes getting through.
They're your motorbikes. So you can be fecally loaded. Oh, I know. It's so Kylie.
Yeah.
You can be fecally loaded and still have those motorbikes going through. One of the things that if you're a GP listening to this, or another doctor, or even a physiotherapist who has access to the pictures of scans that people have, I often find it useful to go through and see, is often the people I see, they will have gone to ED and they will have understandably and probably appropriately had perhaps a CT of their abdo and pelvis to look to check if they have a bowel obstruction or if they have appendicitis or if something else that's going on. And so they'll have scans of when they are, going in with pain.
Having an episode.
And those bowels are just chock-a-block. They are chock-a-block. And so one of the best ways to relieve pain can be trying to get those bowels moving again. And that's partly pelvic floor related because that's our outlet.
There's that crossover, isn't there?
They're almost like two different manifestations of the same thing.
And the bowels and then the nervous system. If everything's tense. Like they bang against each other and they interact, don't they?
Yeah, they're swinging balls.
The swinging balls. Yeah. They're hitting each other.
Yeah. And just for those at home, our producer Rory, every time we say swinging balls, he'll go,
he's such a boy.
So if you hear that in the background, that's
Rory.
That's Rory swinging balls.
Yeah.
They're totally swinging.
Yeah.
And you have to stop them swinging.
Yeah. Because one is perpetuating the other.
Yeah. And they will swing indefinitely until we can stop them. And we actually need to get in and do something about each of those different things.
Yeah.
And so we'll look at something to get the bowels moving. And I'm all for lifestyle. And I actually came into this from a strong interest in lifestyle medicine. And there's always things like fibrous supplements and kiwi fruit and chia seeds, and those things are all good. But often we're in such a mess with the bowels that actually need to start with something much harder hitting than that, which is usually an osmotic laxative. So laxative's a bad word. It's got a bad connotation.
It has such a connotation. People worry about it.
Yeah, that's right. They're very safe. They don't cause you to have a lazy bowel.
And it's better to get the poo out.
You've got to get that poo out. That's really the thing is that real slow, that's that real problem with the outlet obstruction and the cars not moving, the traffic jam.
Hashtag poo out.
Hashtag get the poo out. But that will slow down your transit. And so often people have a transit study as part of this and it'll be like, yes, I have a very slow bowel. And it's like, if you can't poo for long enough, the bowel will slow down in answer to that.
And is that a term people then adopt and go, oh, well, I've got a slow transit and I just have to accept that?
It can be confusing and we talk about this in other ways. Like sometimes a diagnosis of some sort can be helpful if it helps you understand the problem. But what you talk about, which I love, is talk about holding something lightly. So because if you've got this label, I've got a slow transit, it feels like you can't do anything about it.
Yeah,
but
it sort of takes that agency away from you.
Yeah, it makes it even more important to understand why you've got a slow transit, which is almost always going to be at least in part due to the problem with the outlet. And so and things becoming hard over time. The longer the stool sits there, the more it dries out. So your body will take water out of it. And so it becomes harder and it gets very sore. I often ask people in clinic also, and often they can't remember, but if they've had a colonoscopy and they've had that bowel prep, how did they feel after that? Even if it was only for a week or two, because the traffic jam will come back. But often they're like, I felt amazing after that. Yes, so that's bowels.
So we've talked about menstrual suppression. We've talked about menstrual cycling and what to do about that. And we've talked about bowels. And then also pelvic floor, which gets addressed generally quite early on as well.
Has to.
It has to, yeah. Do you want to talk a little bit about that and what?
Yeah, so pelvic floor is, again, feel free to go back to some of the earlier podcasts that we've done on it, but it's that basket of muscles that everything sits in. It is under sort of unconscious or subconscious control. And if there's a lot of pain happening for long enough, it will go into protect mode. So it wants to protect you by keeping out anything that might be harmful. And so it doesn't want to let anything in or out. So poos and wees don't want to come out. How long does it take when you're sitting on the toilet is another question that we ask people. Does it take, pretty much straight away? Poo's ready to come away, wee's ready to come away, or do you have to sit there for a while? Do you have to strain? And if you're having those problems, your pelvic floor is absolutely rock hard and doesn't remember how to relax, even if you're consciously trying to relax it. Pelvic floor also drives so much of the pain that we see. So the back pain, the hip pain, the stabby pain, the leg pain, the lightning ass, as one of my patients called it, the lightning vag. All of those things are all generally pelvic floor mediated.
And you generally see that when we talk about that recognition on people's faces where they're like, yes, that happens to me.
Yeah, and it's very painful.
Yeah,
it's
so
muscle
painful.
spasm. And for those of us who've had a back pain episode or seen a loved one have a back pain episode, like it happens in the movies where someone can't get off the floor for 3 days and that's muscle spasm pain. So that's what you're having if you've got pelvic floor dysfunction, made worse by the bowels, of course, made worse by and complex interaction with the nervous system as well.
Swinging balls back against each other, influencing each other. It's a symphony, isn't it? But a bad symphony.
Yeah, it is. Yeah. It is a bad symphony. And so pelvic floor relaxation through whatever means we have available to us, including diaphragmatic breathing, which naturally relaxes the pelvic floor. Often people need help to learn how to do that.
Yeah, and I think that, and again, I know we've talked about this a lot, and I know I'm picking up on it because it's a passionate area of mine. But a lot of people have said to me lately, "Thank you for explaining that a little bit more," because people talk about breathing, but I just don't understand the importance of it and how it's linked to my pelvic pain and how it can actually help. And so that episode that with Carolyn Berry is a really good one to go back to as well.
Fantastic.
Which kind of unpacks a little bit about, and what I talk a little bit about is why that's important.
You need to understand why you're doing it. Yeah, absolutely.
It's like, well, no one's explained that role, and it does have a few different roles. So
it does, which brings us on to our fourth swinging ball, which is the nervous system.
Yeah,
and nervous system being often in fight, flight, or protect mode.
For so many reasons. And we need to look at and address that through and there's many different ways of doing that. Psychology can be useful. Acknowledging the journey is incredibly useful and validating the experience. Learning about the vagus nerve and the seesaw between sympathetic, fight, flight, freeze, and rest and digest, and learning ways to sort of bring that seesaw back the other way towards rest and digest, sometimes by diaphragmatic belly breathing, by doing things that you enjoy, by doing exercise if that's your thing, in a way that's appropriate, that doesn't aggravate your pelvic floor. So much nuance with all of these. I think it's just pausing and recognising who are you as a person outside of everything else that you've got going in life and the pain and what you've been navigating. Because I think that's what I see a lot as well, is people that have forgotten who they are. It's like, what do you mean? Who am I and what do I do? Yeah. And that importance in the nervous system. And I also want to just touch on sleep as well.
Yeah.
And how important sleep is in this process, and how important that is for regulating our nervous system as well as everything else.
Oh, look, it's incredibly, it's almost like a vital sign that's been missed, and certainly one of the pillars of lifestyle medicine. And it's understandable that if you're suffering with this complex issue, sleep's one of the first things to go, isn't it? You go to bed late, you can't get to sleep, you wake up during the night, sometimes bowels and bladder affecting you, you're stressed.
Again, all those things banging against each other that are having
banging
impact.
Balls.
Banging balls.
Yeah.
And sleep is one of them, which is so incredibly important that we regulate.
Absolutely.
And there's lots of, and this has opened my eyes up to different tools that there's such a big toolkit that we can to help sleep.
Sleep, absolutely. There are certain tools that we use that we'll come back to in subsequent episodes, looking at some of the different medications that we can use to help us with things like the nervous system as well. Because sometimes things are just in such a pickle that we just need a bit of extra help more than, some of the basic stuff that is good for you. But sometimes
it's kind of recognising where you're at right now and what's going to really help turn that wheel to get us out of that bowl back into the happy bowl. The happy bowl, not the pain bowl.
Yeah, that's right. Yeah.
One of the things that you mentioned that I just want to pick up on is hypermobility.
Yes.
And the role that plays in pelvic pain.
Yeah.
Briefly, because we need to deep dive on that.
Briefly, we will come back to hypermobility. We've mentioned this a few times in the podcast, but we almost routinely screen for hypermobility for our new patients coming through. We didn't do that in the beginning because I didn't realise what a large role it played, but hypermobility is huge. And so hypermobility is not about being flexible, and often the hypermobile people are actually quite stiff, but they have stretchy connective tissue. So there's a whole lot going on there, but people with stretchy connective tissue don't as easily maintain even their position in space very well. They have to work quite hard. And so what we see is that if you're a stretchy person, and we can screen for that, and look up the Baton score if you're at home, BEIGHTON, Baton score, is looking at, your levels of stretch. And if you're stretchy, you're not very stable. And so when you're standing, you actually have quite a hard time locking out your joints. And so you have to, people often engage their pelvic floor muscles to keep them stable in space in their bum, and they'll engage often their diaphragm or their thoracic spine to keep them stable in space. Whereas a non-hypermobile person, they can just lock out their joints. They can lock out their hip and knee joints and stand, for example, in quite a stable, low energy way for a long time. Hypermobile people can't do that. But the other really important part is hypermobility is not just about the ligaments and tendons and muscles. It's also things like the bowel are overly stretchy, and so they're more likely to be able to accommodate more poo. And then you have that combined with this overactive pelvic floor, which you're trying to, using to stabilise yourself, makes that problem with going to the toilet even worse. Also means some of the treatments that we use traditionally for pelvic pain, the physio trying to get you to stretch if you're already stretchy. Isn't helping. I've done all the exercises until the cows come home and it's not feeling better. And if we give a fibre supplement, in my experience, again, this is just my experience, to someone who's got a stretchy bowel, they just end up with more poo, and they often end up feeling worse. And so we have to look at different measures. So again,
so in the context of today, which is awareness of
be aware, and we'll cover that in some subsequent episodes as well. The other big one is trauma and neurodivergence, and so what your nervous system is bringing to the table, often in an unhelpful way around your experiences in the world, and also if your brain, in terms of neurodivergence, if you are interpreting the world, if you're a sensory experience and the way that you interact with the world is not the way that you're supposed to, because 90% of the population is neurotypical, and that's how the world is set up, is for that sort of nervous system. You're bringing a whole new level of nervous system instability to an already complex problem. ADHD, tricky to manage some of the complexity and the management if it's hard to manage these things. Autism, in terms of the sensory load, even being able to understand, pick up on sensory signals can be difficult. Engaging with the health system can be difficult. There's so many things, and I think we're really only at the beginning of understanding some of the overlay that happens there. And when we're thinking, what I said earlier was, the question is, if we look into this, is this going to affect our management? And often identifying someone, for me, in my experience, identifying if someone's hypermobile, it doesn't need to be a barrier to treatment. It's not like, oh, you've got another problem to deal with. It's like, okay, can this inform your treatment better, or at least can it help us understand where things haven't gone well, or what didn't work when it was supposed to? Same with autism, ADHD.
Which is why this is such a comprehensive assessment, isn't it? Because like you alluded to with, or not alluded to, you said around the diagnosis, is this investigation going to change my management? It's like all of the questions that we're asking is because it's going to inform the management of your options.
Yes, so important.
Yeah,
so important.
And it's all of them.
Yeah.
And all of them are important.
Yeah. And I think the other take-home message is the earlier we start fixing this, the better. The longer you're in the bowl, the deeper the bowl gets.
Yeah.
It's like
which doesn't mean we can't get out of the bowl.
Yeah,
but it's going to take a bit longer.
It's like those, like when you go travelling and people touch on a certain part of a statue or something and it wears it away. And it's like the longer you're in the bowl, the deeper the bowl gets.
Yeah.
And it can be harder to get out of. And we definitely know that the earlier you can get onto managing this, the easier it is to get out of it.
So seek help early.
Yeah.
Yeah. If you've got any pain or that you think is normal, perhaps it's not.
Yeah, absolutely. So that's really important as well. So, but getting good quality help is is not always easy.
It's not.
And so I guess that's what we hear with the podcast is just to help people start knowing what questions to be asking and how to be approaching their problem. So
and observations, and hopefully this podcast that we've done today with yourself has again reiterated these key areas that which we know can impact your experience of pain.
Absolutely.
Yeah.
So hopefully as a summary episode, this helps just bring together some of the ideas and also likely to introduce some of the topics that are coming. The bladder, the ADHD, the autism, the trauma, the hypermobility. Looking again at menstrual suppression medication, looking again at some of the nervous system medication.
Yeah.
Looking again
in
at surgery.
In conjunction with other things. And again, it's like it's a buffet, isn't it? You can put different things on your plate. You can take things off. You can make your husband or partner eat the thing that you didn't want. Like it's
absolutely
it's changeable and it's not a one size fits all.
And
isn't it?
what suited you last year might not suit you this year.
Yeah, absolutely. But any last minute thoughts, and are there any common misconceptions? Is there anything we've missed?
Main thing is to pick up on what Associate Professor Matthew Leonardi said on the podcast earlier. Let's just stop thinking about things so simply. If it's being presented as a very simple fix, it probably isn't. And so find some good help if you can, and think of the big picture. Zoom out always.
Dr. Alicia Macro, thank you very much for your insights, very valuable insights today.
Pleasure.